Our spring 2007 lecture series begins with tonight's discussion, Antioxidant Vitamins, the Cornerstone of Integrative Cardiology. My name's James Roberts. I'm board certified in internal medicine and in cardiology, and I've been practicing invasive and integrative cardiology in Northwest Ohio over the past 20 years. And I'm the medical director of Comprehensive Heart Care, the ECP Center of Northwest Ohio, and the Advanced Magnetic Research Institute of Northwest Ohio, and I'm a site investigator of TACT, the Trial to Assess Chelation Therapy. Most of the points that I make tonight in our discussion on antioxidant vitamins are discussed in our book, Reverse Heart Disease Now, which is a patient manual of integrative cardiology written by myself and my colleague and friend Stephen Sinatra. The major points of tonight's presentation are that undefended free radical attack leads to LDL cholesterol oxidation, vascular wall inflammation, and endothelial dysfunction. LDL oxidation must occur before coronary disease can develop. Antioxidant vitamin deficiency is associated with an increased coronary risk between and within societies. Antioxidant supplementation inhibits test tube LDL oxidation and controls atherosclerosis in animals. In humans, antioxidant supplementation is associated with a 30 to 50% decrease in the risk of developing coronary disease over 4 to 10 years. In patients with known coronary disease, supplementation helps stabilize the plaques, and when combined with LDL cholesterol reduction can produce disease regression. The arteries open up anatomically. Acute coronary syndromes, unstable angina, heart attack, are characterized by oxidative stress, vascular wall inflammation, and endothelial dysfunction. Oxygen-derived free radicals mediate reperfusion injury. Antioxidants restore endothelial function, attenuate reperfusion injury, and have an anti-inflammatory effect, producing clinical benefits above and beyond that related to their basic anti-atherosclerotic, anti-LDL oxidation effect. Vitamin E has been shown to decrease 2-year event rate in patients with established coronary disease by 50 to 75%. Vitamin C decreases disease progression over 10 years by 2/3, and event rate by greater than 50%, regardless of the baseline degree of atherosclerosis you might have. Antioxidants improve outcome following bypass surgery, balloon angioplasty, heart attack, transient ischemic attack, and even cardiac transplantation. Antioxidants protect not only the heart, but every organ in your body: kidneys, lung, brain, prostate, and other internal organs. Antioxidants are protective, maybe even therapeutic against certain malignancies. Environmental and dietary toxins are depleting our antioxidant defenses. Dietary vitamin sources are lacking or not utilized in our society. Therefore, vitamin supplementation in an appropriate dose, individualized to one's health status, is recommended for all of our patients. Great benefits are in store for our patients and for society in general as we learn more about nutritional medicine and gain access to second generation and comprehensive nutritionals. We will talk a little bit about the therapeutic role of antioxidants in people with advanced cardiovascular disease, but the focus tonight is on prevention, how to prevent the development of cardiovascular disease. We're talking prevention, we're talking risk factor reduction. My job is to identify within a patient all the causes of heart disease, all the risk factors they may have, and then come up with means of dealing with them. And a discussion of antioxidants fits in because if you smoke, if you're diabetic, if you're iron overloaded, if you suffer from heavy metal overload, this will deplete your antioxidant vitamin mineral defenses. You will suffer free radical stress. This leads to endothelial dysfunction, LDL oxidation, inflammation, hypertension, insulin sensitivity, and a downhill spiral to cardiovascular disease and malignancy. Now, when you leave tonight, I don't want you to go out and buy a bottle of vitamin C and say, yeah, I'm doing what I need to do, or a bottle of vitamin E, or a bottle of selenium and say, yes, I'm going to take antioxidants. That doesn't make any sense to me. What I'd like you to leave with is an understanding that Mother Nature, our maker or evolution, expects us to take in a wide variety of antioxidant vitamins and minerals and cofactors. You see, there's many different free radicals that want to oxidize us, many different sources of free radical stress. Our body, as we generate energy by burning sugar and fat, creates free radicals such as superoxide and hydroxyl anion. Xenobiotics, that's a technical name for the drugs we give you, cause free radical stress. The toxins in our environment, lead, mercury, and cadmium, cause free radical stress. We physicians and our zeal to help you can cause free radical stress. I'm a 51-year-old marathon runner with an extremely low cholesterol, yet I have an abnormally thickened carotid artery intima media thickness. Why? I've done too many heart catheterizations. I've been exposed to ionizing radiation, just as have my patients. When we rapidly open up closed arteries with balloon angioplasty, or if we close and open an artery with vascular reconstructive surgery, we're exposing you to free radical stress. We want to neutralize free radicals. So what's a free radical? A free radical is an atom with one as opposed to the normal 2 electrons in its outer shell. Normally we have 2 electrons in the outer shell spinning in opposite directions, and that produces molecular stability. The free radical has only one. It's unstable and reactive. It's going to snatch an electron from the next atom, quenching its thirst for electrons, but damaging this atom, creating a new free radical. The new free radical is going to snatch an electron from the next atom, damaging that atom and creating a new free radical. If an antioxidant is not introduced, antioxidants will download electrons and quench the thirst, put out the fire, without becoming free radicals themselves. If an antioxidant is not introduced, a chain reaction will occur, enough atoms will be damaged, then the molecule that this is occurring in will be damaged. If enough molecules are damaged, this region of the cell will be damaged. If it's the nucleus, the cell will turn cancerous. If it's the mitochondria, you can't make energy, you have chronic fatigue. If it's the cell membrane, the cell blows up and dies. If this is occurring in an LDL cholesterol particle, it becomes oxidized and atherogenic, more likely to layer out in your arteries as plaque. Where do these free radicals come from? We generate them. We will burn sugar and fat in the presence of oxygen to make energy. We actually strip carbon atoms, we strip electrons from the carbon atoms of the sugar and fat, and we transfer that energy into useful biochemical energy. We have to transport these electrons and give them to an electron recipient, which is oxygen. 98% of the time, oxygen gets 2 electrons. It's O2, it's stable. 2% of the time, oxygen gets only 1 electron, and that forms the free radical superoxide, which can convert to hydrogen peroxide. In the presence of iron or the toxic heavy metals cadmium, aluminum, lead, or mercury, superoxide or hydrogen peroxide can be converted into the very damaging free radical hydroxyl. This is what Li is. So our body is making free radicals all the time. And energy production is not the only endogenous source of free radicals. Many physiologic processes produce free radicals. When we're killing bacteria, our white cells are making free radicals to throw at the infection. And as a downside, it'll damage the area in the body where the infection occurred. So if you have a severe pneumonia, your white cells are going to make free radicals to kill the bugs, but it also will damage your lungs and scar them. Sunlight causes free radical stress. Overzealous sun worshipers, their skin is dry and leathery. That's free radical stress. So primitive man was exposed to free radicals. Modern man has an even greater problem because the byproduct of the industrial age is exposing us to free radicals. Cigarette and tobacco smoke, heavy metals, industrial pollutants, ionizing radiation, many of the drugs we give you cause free radical damage. Adriamycin is a very useful chemotherapeutic drug, but the adriamycin free radical will damage the heart, limiting the efficacy of this approach. Alcohol is non-toxic, but the alcohol-free radical damages the liver. There's a street drug that is non-toxic, but your body will convert it into a free radical form. It goes to the substantia nigra, the area of the brain that controls motion, and causes Parkinson's disease, which is a free radical disease. So we're being bombarded with free radicals far more than Mother Nature programmed us to deal with. So how come we're not all dead? Now, if Mother Nature gave us an energy generating system that as a byproduct caused these potentially toxic free radicals, one would predict she gave us a means of neutralizing the free radicals so generated, and that is our mineral-based antioxidant defense. Superoxide dismutase will download an electron to superoxide, neutralizing it, but because of its special structure, it doesn't become a free radical itself, it just becomes used up. And then you have to make more. And you can if you've got enough manganese, copper, and zinc, but most of us don't. This is critically important. 1/5 of the protein in your body right now is superoxide dismutase because the antioxidant defense is so critical to our physiology. Glutathione reductase will neutralize hydrogen peroxide if you have enough selenium, and most of you don't, but we do not have a specific mineral-based defense against any hydroxyl that leaks through or against any of the environmental free radicals. Here we have to fall back on our vitamin-based antioxidant defense system. Vitamin E is our primary intracellular antioxidant, backed up by CoQ, lycopene, and beta-carotene. Now, if vitamin E is used up, if it's given away its electrons, it can recharge itself. What happens is that vitamin E can migrate to the periphery of the cell, and then vitamin C in the circulation will download an electron to vitamin E, so vitamin E can go and fight more free radical battles. But then eventually, if you're going to run out of vitamin C, and then the bioflavonoids that back up vitamin C are lost, and then the free radicals win and you get oxidized, and that's not what you want. I'll give you some examples of what happens in nature. If you leave metal out and it rusts, that's free radical damage. If you take butter and put it in the sun and it turns rancid, that's free radical damage. You bite an apple, it turns orange, that's free radical damage. When I was a younger doctor, I hung out in the hospital a lot, and I wore a coat and tie to impress everybody that I was professional, and I was often doing urgent invasive procedures on people. And I was called to put in an urgent temporary pacemaker. And you know what we do, we numb you up and we stick a needle under the clavicle into the vein and pass in the pacemaker. And I poked the artery by mistake. So all this blood splashed back at me and got on my coat. So we took care of the patient, put in the pacemaker, the patient was fine, and then I got this coat with this big old blood stain on it. I didn't know what to do. The nurse says, well, we know what to do. Here, they took my coat and they poured hydrogen peroxide over the blood stain. And there was this bubbling chemical reaction, and yes, the blood stain lifted up, but I can't wear the coat anymore because it also kind of destroyed the fabric. That's free radical damage. Your body is making this stuff right now. Hydrogen peroxide and superoxide and hydroxide, which is kind of like lye. We're not that interested in my sartorial status, and you know I don't wear a coat and tie anymore, and you're here to learn about cardiovascular disease. And this is the key slide to my talk. This is the metabolic order of battle. These are the free radicals, these are facilitators, these are antioxidants, and this is the sequelae of oxidation. And this is really important, so we'll have a little skit here tonight, and you're going to participate. You're going to be in an endothelial cell. This is a cell that lines the coronary arteries, that makes nitric oxide, the Teflon coating. This will be the circulation. Up here will be the liver, and I'm going to be an LDL particle. And this is occurring in one of my new patients that I talked to them about their diet, so they've not been eating trans fats, they've been eating fish oils, and they've been taking a lot of vitamins. So this LDL that is formed doesn't have a lot of readily oxidizable fatty acids in it. It's got the normal 5 vitamin E's. And we've been vilifying cholesterol and saying that it causes heart disease, but Mother Nature didn't give us cholesterol to cause heart disease. Mother Nature gave us cholesterol because we need it to make steroid hormones or bile acids or new cell membranes. When we're growing new arteries with EECP or trying to regenerate the heart from stem cells with MME, we need cholesterol to make new cells. So I'm floating around in the blood right now, and I want to be put to good use. And I come across a cell, you guys here, that needs some cholesterol. And what happens when a cell needs cholesterol? It sticks out of its cell membrane a molecule like a molecular hand called the LDL receptor. It says, I need some LDL cholesterol for good use, and I'm going to be brought into the cell, and I'll be put to good use. That's the way Mother Nature planned it. Okay, so the next day, now we're the next day. The guy's really been working on his diet and kind of been denying himself the things he likes, and he had the blood drawn. So on the way home, he gets a super duper double whopper Big Mac plus loaded with trans fats. And his other doctor said vitamins don't work, it's just expensive urine, so he didn't take them. So this LDL the next day is full of a lot of bad fats. It only's got 3 vitamin E's. So it's floating around in the circulation. It wants to be put to good use, but none of the cells need cholesterol anymore. They've had their fill. They've withdrawn their LDL receptor. And if the cells have withdrawn their LDL receptor, if they don't need it anymore, I can't get in. No matter how high your cholesterol is, you can't overfill your cells with it because they won't take it. I don't care if your cholesterol is 400, if your cells don't need it, they won't take it in. It's benign stuff. So he can't find room in the cells, so to speak, so he's floating around and the free radicals start to work at him. He has a cigarette. That's free radical stress. So he's got to use up one of his 3 vitamin E's. He's driving home from work, rolls down the window, gets a lung full of pollution. There's another vitamin E. His body, he has a cold, so his body's fighting it. Oh, there's some more free radical stress. He has another cigarette. Uh-oh, he's now out of vitamin E. So what'll happen is vitamin C from the circulation can download an electron, so vitamin E can keep going into battle. But if this keeps happening and the guy's exposed to free radical stress, eventually we run out of vitamin C and the LDL particle becomes oxidized. Now when the LDL becomes oxidized, it undergoes a configurational change. It no longer looks like a normal LDL. So I'm going to wear my oxidized jacket to signify that I'm now an oxidized LDL. So I'm floating around in the blood and I'm an oxidized LDL, and I come across a cell that actually needs some cholesterol. It has the molecular hand out there, but I don't fit anymore because I'm not a normal LDL anymore and I can't get in. But I look to the immune system like a cell that's been invaded by a bacteria or a virus or a cancer cell. I'm no longer a normal looking cell. So the Pac-Man cells, the macrophages, the monocytes, they engulf me, they put a gun to my head and bring me into the cells where they're going to digest me and kill me. That's their job. And they put a gun to my head. But I'm an oxidized LDL. I have a more powerful gun. I have a lightsaber. And what the oxidized LDL will do is release chemicals that will immobilize the white cell within the endothelial cells that line your artery, and they release chemicals that will cause other white cells to come in from the circulation into the artery wall and chomp down on other cholesterol, and then they die. So we have dead white cells that have been chomping down on cholesterol. Those are pus cells, basically. Isn't that fun? They're pus cells, so a boil is forming within the artery wall due to oxidized LDL. Now, the oxidized LDL will also release chemicals that are toxic to the endothelial cells. The endothelial cells can no longer make nitric oxide, so arteries become stiff and spastic, and oh, what happens? Our blood pressure begins to rise. And this is happening in our 20s and 30s. We have these fatty streaks in the artery wall. But that's not all that narrows the artery. We have smooth muscle cells that live in the middle layer and that are kept from migrating into the endothelium and encroaching on the flow area by nitric oxide. But the oxidized LDL has damaged the nitric oxide, so smooth muscle cells begin to migrate in to the inner wall, the intima, and they thicken it up. So now we have a 20, 30, 40, 50% narrowing with smooth muscles and dead white cells and oxidized cholesterol. But that doesn't harm us. That doesn't bother us a whole lot. But the oxidized LDL will release chemicals that cause our platelets to be sticky. So arteries tend to clot. The leading edge of this atherosclerotic tumor, the leading edge, the shoulder, is composed of white cells full of freshly oxidized LDL. It's thin and friable, and it can rupture, releasing its atherosclerotic inflamed gruel into the flow area, acutely closing off the artery. So you can go from a 60% narrowing to 100% narrowing just like that. And that's the terminal event causing the heart attack. So at all levels of this disease, from the beginning to its propagation to the terminal event, plaque rupture or clot, oxidation plays a role. And if we do balloon angioplasty or bypass or even a heart transplant, oxidation plays a role. So if no matter how far your disease is advanced, if we can intervene with antioxidants, we can help you at any stage of this disease. And I'm going to spend the rest of the talk backing up those statements. We can look at test tube studies. If I draw your blood and look and take your LDL and put it in a test tube and add in mercury, I can see how long it takes to oxidize your LDL. It is easier to oxidize the LDL of a smoker than a non-smoker, a diabetic than a non-diabetic. If we see how long it takes to oxidize the LDL of a smoker, and then we have you take antioxidants for 2 weeks and repeat the experiment, it's more difficult to oxidize your LDL. In animal studies, animals don't get heart disease, but if you make them vitamin C deficient or do experimental angioplasties or make them smoke cigarettes, they will get atherosclerosis that progresses more rapidly if you render them vitamin deficient. Conversely, if you treat them with antioxidants, they become more resistant. We are not really interested in test tube studies, and most of my patients are not rats, only a few. So we want some human studies for the rest of you, and we have many. One of the very first studies that came out was the European cross-cultural study. They looked at 16 cultural groups in 12 European countries that varied widely in their cardiovascular death rate. And they wanted to know what factors are most important in explaining these different coronary death rates between these societies. So they measured vitamin levels, looked at all the other risk factors, put this information into a computer to assess the relative importance of each risk factor. They found that differences in cardiac mortality between these societies, 62% of the difference could be explained by differing vitamin E levels. If you look at vitamin E and cholesterol, that explains 79% of the difference. 83% of the difference could be explained by understanding differences in E, cholesterol, and vitamin C. It's not vitamin deficiency. It's not free radical excess. It's not cholesterol excess. It's too much oxidized cholesterol. So it makes sense. The more cholesterol you have, the more it can be oxidized, the lower your vitamin status, the less able you are to prevent oxidation of cholesterol. Let's look at LDL oxidation and future event risk. This was a long-term risk factor study called MONICA. We're going to look at 356 men free of diabetes or cardiovascular disease at study entry. We're going to do a baseline clinical evaluation and lab parameters. We're going to follow them for 3 to 6 years. Of this group, 88 had an event, a fatal heart attack, non-fatal heart attack, sudden cardiac death. The rest, 258, age-matched controls, had no events. And we're going to correlate the baseline laboratory parameters with risk of a future event. Compare future event risk of the middle and upper terciles of a risk factor versus the risk of the lower tercile. So here we're going to look at LDL. In blue are the individuals in the middle third of LDL, and they were 50% more likely to have an event than those in the lower third. Those in the upper third, the upper tercile for LDL, were 2.4 times as likely to have an event. So LDL is important, but it's nothing compared to oxidized LDL. Those in the middle tercile were 80% more likely. Those in the upper third, just the upper third, were 4.3 times as likely. It's not just the cholesterol or the LDL, it's the oxidized LDL that harms us. Superoxide dismutase is the antioxidant that squelches superoxide. Seems like we ought to have a lot of that. 40 subjects, 20 with known coronary disease, abnormal stress perfusion studies, 20 healthy controls. Let's measure superoxide dismutase levels. At baseline, the coronary patients have only half as much. That makes sense. They couldn't defend against oxidation. They oxidized their LDL. Of course they're going to have coronary disease. With exercise, our antioxidant defenses should rise. They rose a lot more in the healthy people, and during recovery, they didn't fall as much. So our people with cardiovascular disease have a poor antioxidant defense system. That's why they have cardiovascular disease. Selenium, we need that to regenerate glutathione to deal with hydrogen peroxide. Here we're going to look at 400 patients referred for coronary angiography. We're going to measure their blood selenium levels. We're going to look at the number of vessels they have blocked in their heart, their legs, their neck. Individuals with clear arteries had a selenium level of 77. One vessel, 71%. Two vessel disease, 64%. Three vessel disease, 50. All right? The lower your selenium, the more extensive will be your cardiovascular disease because you can't prevent LDL oxidation. The Nurses' Health Study was published about 12 years ago in the New England Journal of Medicine. It's a prospective cohort study. Here we're going to look at 90,000 initially healthy female nurses in the United States. None had diabetes, hypertension, or cardiovascular disease. We're going to look at their vitamin intake from food and supplements and stratify them into quintiles, 20% brackets. We're going to follow them for 8 years. 552 of the 90,000 nurses had cardiac events, and we're going to look at whether a high or low intake of a specific supplement was associated with an increased or decreased risk of cardiovascular disease. Let's start with vitamin E. The nurses in the upper quintile, upper 20% bracket for vitamin E from all sources took in 208 units. Compared to those in the lowest quintile, they took only 2.8 units. They experienced a 34% risk reduction. If we look at vitamin E from diet alone, excluding vitamin supplements, the nurses in the upper quintile took in only 7.7 units. We don't get that much from our food. Still, compared to the nurses with the lowest vitamin E intake, they enjoyed a 21% risk reduction. Nurses that took in a multivitamin with 30 units of E had a 22% risk reduction. Those that took in a multivitamin from a health food store that had 100 units of E, which was a lot back then, 41%. Nurses that took in more beta-carotene and vitamin C also had risk reduction. This was repeated in male health professionals, the same thing. People who habitually take in a lot of vitamins and minerals enjoy a reduced risk of subsequent cardiovascular disease. Is this proof positive? No. It could be that nurses who were smart enough to take antioxidants 10 to 15 years ago were also smart enough to exercise, not smoke, follow a good diet. But it's certainly a strong association. To prove the point, you have to do an interventional study. We have the Harvard Physician Study. This was actually constructed to see if aspirin would prevent cardiac events and would beta-carotene reduce the risk of cancer. It involved 22,000 physicians. When the concept of antioxidants in the secondary prevention of cardiovascular disease came out, the researchers looked at their data and identified 330 of the physicians that had known coronary disease at the beginning of the study. They'd either had a heart attack or they had stable angina. Now, these 330 physicians were randomly divided into 1 of 4 groups. One group got beta-carotene 50 milligrams every other day and 1 adult aspirin. 25% of them got aspirin alone, 25% got beta-carotene alone, 25% got nothing. And it was a randomized double-blind study. No one knew who was getting aspirin or beta-carotene or both. And they followed them for 6 years, and they found in the doctors who took beta-carotene enjoyed a 44% decrease in coronary event rate, heart attack, bypass surgery, angioplasty. And if you add in stroke, it's basically a 50% decrease. Wow. For the group of these 330 doctors, 28 had heart attacks. 17 in the placebo and aspirin alone groups, 11 in the beta-carotene group, that's our 44% reduction, and none in the beta-carotene and aspirin group. I reject the label alternative medicine when I recommend antioxidants. I say it's integrative medicine. I am happy to take the best of standard medicine. I do lots of heart caths, too many heart caths actually, and I send patients for bypass all the time. And if standard medicine has something good like aspirin, I'll take it. If complementary medicine has something good like antioxidants, I'll take it. I want to get the best of both worlds. The doctors that got the best of both worlds here, the beta-carotene and the aspirin, had no heart attacks, which is what we want for you. So I'm quite interested in integrative medicine and antioxidants. I push antioxidants on everybody, but I have to be fair and balanced. There have been studies that show that vitamins don't work, and I have to share them with you. In fact, this sad fact that vitamins really are expensive urine were broken to the American public a few years ago by noted scientists Dan Rather and Connie Chung. They talked to you about the Finnish study. Now, this is an interesting study. 30,000 middle-aged Finnish smokers, they all smoked at least one pack per day for 20 years, on average 36 years. And none had evidence of cancer at the beginning of the study. It takes, though, about 6 years for a cancer to show up on an x-ray. And these Finnish smokers were randomly divided into 4 groups. One group got 75 units of vitamin E. Not 100 units, not 400, but 75. Another group got 20 milligrams of beta-carotene. Third group got both. Fourth group got placebo. Look for evidence of lung cancer over 6 years. And they found that your baseline blood levels of E and beta-carotene were protective. That would reflect a diet, but supplementation had no effect. So they concluded that vitamins don't work because over the 6-year period, they didn't show a reduction in cancer or any effect on cardiovascular disease. Now, the authors, when they published this study, didn't conclude that. They kind of apologized because it was not a very good study. And we have to understand it takes 5 years to plan these studies, then 10 years to execute them. By the time they get published, the scientific foundation for the study has changed. And this study doesn't really show that vitamins don't work, and we're going to discuss that. First of all, did they give enough vitamin E? You know, if I'm going to give you Lipitor to lower your cholesterol, some people respond to 10 milligrams, others need 80, and I will titrate it up till I get the job done. If we did a study of Lipitor for cholesterol reduction and all I was allowed to use is 5 milligrams, and your cholesterols didn't fall, will we conclude that Lipitor was worthless? We would say, no, that was a stupid study. You didn't give enough to get the job done. Same with blood pressure drugs. Well, here's the point behind vitamin E is not to take vitamin E, it's to block LDL oxidation. We need to give you enough to get the job done. Here we're going to look at a study measuring the LDL lag time to oxidation before and after various doses of vitamin E. Here's placebo, that doesn't do anything. Here's 150 units of vitamin E, it doesn't do anything. Here's 225, it does something. Maximum effect is 1200. 150 doesn't do anything, but in this study they gave 75. That's not enough. And they just said take it. They didn't talk about the timing. When should you take your vitamins? Here's a study of adult onset diabetics. They get a standard American Diabetic Association breakfast and lunch, and then for dinner they get a Big Mac meal. Lots of trans fats. And you're going to put them on 4 treatments in random sequence. One group gets E800 and C1000 before breakfast. Another group gets E and C right before the high-fat dinner. Another group gets no vitamins. Another group, they were bad boys. They were sent to the lab without a dinner. And we're going to measure C-reactive protein and Pi1 at dinner, at a high-fat dinner, and 1, 2, 3, and 4 hours later. Now, if we look at vitamin E levels, if you took it in the morning, it's still high at dinner time and for 4 hours. But if you're just taking it dinner, it's very low when the food hits your stomach and it goes up. If you take vitamin C in the morning, the levels are declining by dinner. If you take it with dinner, they're starting to rise up. That kind of makes sense. If we look at C-reactive protein, when we eat a fatty diet, we have inflammation, C-reactive protein. We don't like that. And if you don't take vitamins, you have a high-fat meal, your CRP goes up. If you took your vitamins before breakfast, it doesn't go up. But if you took them right before supper, it actually falls. So there's a difference in what time of the day you take the vitamins. If we're looking at Pi1, which is a clotting factor, we don't want to see a high Pi1. It rises if you don't take vitamins, and if you take your vitamins right with supper, there was no effect. If you took your vitamins in the morning, there was some effect. So it depends the time of day. The message here is you split your vitamins throughout the day. My patients take 6 multis a day, 2 with breakfast, 2 with lunch, 2 with dinner. I want you to have 24-hour-a-day coverage, not just coverage for one meal. But in this study, they just gave them one dose and said, take it. Is one antioxidant enough? Here we have the ASAP study done in Finland, 520 Finns with a cholesterol around 200. You look at carotid artery intermediate thickness. The more rapidly that progresses, the more rapidly is atherosclerosis progressing in your body, the greater is your risk of an event. And you're going to do the baseline carotid IMT. You're going to randomize them to vitamin E, 272 units, 500 milligrams of vitamin C, both or placebo, and repeat the carotid IMT periodically over the next 3 years. With placebo, plaque thickness increased by 20 micrometers per year. Vitamin E alone provided 5% protection. Vitamin C alone, 5% protection. Vitamin E and C together, remember C interacts and recharges with vitamin E, 45% protection. Had they done this with a 6-a-day vitamin and mineral, they would have gotten much more protection. In non-smokers, vitamin E was not as, and C was not as effective as in smokers. Smokers got more out of it. Why? Because they're under greater free radical stress. The more you need the vitamins, the greater your free radical stress burden, the greater will be your therapeutic effect. They continued this study over 6 years, and in the placebo patients, they filled up with plaque much more readily than the vitamin patients. Now, again, the point is Mother Nature expects us to have a team, interlocking, mutually supportive antioxidant system with all these vitamins and minerals in your body. That's what works. Now, the situation in Finland is a little bit different. The Finns are mercury toxic. They have the highest levels of mercury toxicity in the world. They're very, very low in selenium. There's not a whole lot to do in the land of the midnight sun, during the winter, except drink. And they drink a lot, which destroys vitamin E. Only 1/5 of these men stop smoking. So they're under tremendous free radical stress, and we give them this wimpy little dose of vitamin E and expect something to happen? That's a joke. It's not enough. It's like giving 1 canteen of water to a man that's dying of thirst on the Sahara. It's not going to do anything. But let's say they took 1,200 units of vitamin E, a really good therapeutic dose. That's like having a car with 1 Michelin and 3 flats. So these studies that show that vitamins don't work, they're pretty stupid studies. They don't make any sense at all. So when you read a newspaper article about the experts say vitamins don't work, these were mostly stupid studies, because Mother Nature wouldn't expect you to take in one antioxidant alone without its teammates. That's just stupid. Now, the physicians that have said vitamins don't work were thrown into a state of chaos by this study, the Cambridge Heart Antioxidant, or CHAOS study. We're going to look at just over 2,000 men and women with newly diagnosed cardiovascular disease. They all had undergone their first heart cath, newly diagnosed cardiovascular disease. 90% had angina or an abnormal stress test, none with prior vitamin E use. And following the heart cath, you're going to randomize them, half get placebo, half get vitamin E. Of the vitamin E patients, half got 800 units, half got 400 units. You're going to follow them for 510 days, a year and a half, randomized double-blind study, and all therapies were applied to an equal percentage of the placebo and the vitamin E patients. And we're going to see what happened. First of all, what happens to their cholesterol? Everyone's focusing on cholesterol. Nothing happened to their cholesterol. Cholesterol didn't fall with placebo or with vitamin E. When you took vitamin E, your vitamin E or alpha tocopherol levels rose. So antioxidants don't lower your cholesterol, they raise your antioxidant defense systems, right? What effect does that have on outcome? Of the group, there were 55 non-fatal heart attacks. The rate in placebo was 4.2%. With vitamin E, it was 1.35%. This is event-free survival without a heart attack. Here's vitamin E, here's placebo. Daily supplementation with vitamin E decreased the 510-day heart attack risk by 77%. That's fantastic for pennies a day. 50 cardiovascular deaths occurred, and there was no difference between placebo and vitamin E. However, when they reanalyzed the data and excluded the subjects that didn't take their vitamin E, that were non-compliant, if you exclude them and look at the people that actually took their vitamin E, there was protection against death. But even including those that were not compliant with their vitamin E, overall cardiovascular event rate, 6.6% with placebo, just under 4% with vitamin E. Vitamin E decreased cardiovascular event rate by 47% for pennies a day. So when a doctor says vitamin E doesn't work, they're just not thinking correctly. There's something wrong with their mind. Maybe there's a problem with blood flow to their brain. Maybe they're having TIAs. Here, let's look at vitamin E and stroke risk. 100 subjects with transient or incomplete cerebral ischemic events. Minor incomplete strokes, strokes to the eye, to the retina, transient ischemic attacks, they're all at risk for further ischemic event and stroke. Now, these events involve abnormal blood platelet function, microclotting that is transient. The platelets aggregate. After they aggregate, there's a free radical burst, and then the platelets adhere to the vascular wall. Aspirin blocks platelet aggregation. That's why we recommend it. Vitamin E blunts the oxidative burst and platelet adhesion. An integrative cardiologist would say, maybe we ought to give our patients aspirin and vitamin E together to cover all the bases. So what they did, these 100 patients were randomized to aspirin or aspirin plus E, 400 units a day. You're going to follow them for 2 years. Look at stroke, recurrent TIA, other cardiovascular events, or bleeding risk, because, as you know, vitamins make you bleed. Total events at 2 years, 40% with aspirin monotherapy, 27% with aspirin and vitamin E. In other words, 13 out of 100 people who would have had an event were spared by adding vitamin E to aspirin. Stroke risk, 13% with aspirin, 6% with aspirin and E. Recurrent TIA, 4%, 2%. There was no increase in bleeding. Vitamin E doesn't make you bleed. That's just not true. No change in cardiovascular events, low at 4%, but this was not their hot circuit. Their coronaries were not inflamed. It was their carotids that needed that were on fire, that needed to be put out. So phenomenal benefit in TIA and stroke risk. Still, many people say vitamins don't work, and I wonder, what planet have you been on? So for these guys, we have the SPACE study, secondary prevention with antioxidants in end-stage renal disease. 196 dialysis patients with known cardiovascular disease, a very high-risk group. If you have kidney disease, you have endothelial dysfunction, high homocysteine, dialysis generates free radicals. So this group's at very high risk. So here we're going to randomize them to 800 units of E or a placebo and follow them for 2 years. This was done in Israel. Everybody's on the same computer system. It was very easy to track outcome. And it was a randomized, double-blind, multi-center study. The primary endpoint, a composite of heart attack, stroke, new peripheral vascular disease, vitamin E provided 54% risk reduction, decreasing the event risk from 33% to 15%. In other words, 18 out of 100 people that were going to have an event didn't have it because they took vitamin E. Heart attack risk falls by 70%, unstable angina risk by 50%, cardiovascular death by 39%, peripheral vascular disease by 61%. Now, if a cholesterol-lowering drug lowers your event risk in a young, healthy person from 2% to 1%, 50% risk reduction, but you're saving only 1 out of 100 people. Here, we're saving, here with cardiovascular death, you're saving 6 out of 100 people for pennies a day. Tocotrienols. Now, in the CHAOS study, you may have noticed the patients that took 400 of E did a little bit better than those that took 800 of E. More is not necessarily better in nutritional medicine. The only way to get into trouble with a nutritional supplement is to take in so much that you block the absorption of other nutrients that are absorbed through the same pathway. Vitamin E is Tokoferol, and it exists in 4 forms, alpha, beta, gamma, delta. For some reason, we give you only alpha tocopherol. I don't know why we do that, but that's what we do. And if we give you so much alpha tocopherol, we're going to block the absorption of gamma tocopherol from your diet, and we'll create a secondary deficiency. So that's why I recommend 400 units a day. That was the dose that worked best. Better yet, my patients take a brand of vitamin E called Unique E that has alpha, beta, gamma, delta, so we avoid that problem. Vitamin E can also exist in the tocotrienol form. This is vitamin E with a double bond in its side chain. It's more mobile. It's vitamin E that swims. It's a better antioxidant, and it has a better effect on platelets and cholesterol. You can get tocotrienols from palm oil. And here's a study done in Malaysia where their intervention was a substance called POMVT, which has gamma and alpha tocotrienol, a more powerful antioxidant than plain old vitamin E alone. We're going to look at 50 subjects with symptomatic carotid disease. They'd had a TIA or a non-disabling stroke. They had a 15 to 79% carotid narrowing. If it was 80 or above, they had surgery. If it's below 80, they could be in this study. And at baseline, you're going to look at their lipids, T-bars. This is thiobarbituric acid reactive substances, which is a measure of oxidative stress. And we're going to look at the severity of carotid narrowing, grade them as 0 to 15%, 16 to 49%, 50 to 79%, or 80 to 99%. Randomize them to get placebo or the tocotrienol, and then reevaluate them at 6 and 12 months. All other therapies were continued except for statins that would lower their cholesterol. And there was no effect on cholesterol. We made these poor patients take this nutritional supplement, and oh, their cholesterols did not fall. Isn't that awful? They fell with placebo therapy. They didn't fall with tocotrienol. The HDLs went up a little bit in both groups. So what? Big deal. I don't care. All I care about is your outcomes. If we look at T-bars, a measure of free radical stress, it worsened with placebo therapy. People with atherosclerosis tend to become more and more inflamed and oxidized over time. The tocotrienol patients, the oxidative fires were put out. You don't lower the cholesterol, but you're putting out the oxidative fire, and you're going to be lowering the oxidized cholesterol levels. What happened to the patients? If we repeat the carotid ultrasound at 6 and 12 months, we see disease progression with placebo therapy, as you'd expect. 8% progressed by one category, 12 by two categories. At a year, 40% of the placebo patients had progressed by one or two categories. Only 8% of the antioxidant patients had progressed by one category, and 24% opened up by one level, 4% opened up by two levels. We didn't lower your cholesterol, but we blocked oxidation, and your carotid arteries actually opened up. So what's more important, cholesterol or antioxidant defenses? A study called CLASS, cholesterol-lowering atherosclerosis study, took men following bypass surgery, randomized them to diet versus diet or drugs to lower the cholesterol. The diet and drug group got their LDL down to 100, they did better. And then I started recommending aiming for an LDL of 100. Some of these men took E, some of these men took C. And what we're going to find, if you get your LDL down to 100, that retards overall disease progression, regresses the titer narrowings. Men that took E above 100 milligrams a day, this reduces overall disease progression, reduces the less tight narrowings. Vitamin C regresses the tighter narrowings. But the men that got their LDL down to 100 and took E and took C, they all opened up. The less cholesterol, the less to be oxidized, the more antioxidants, the less oxidized, your arteries are going to open up. Now, when we've been presenting studies showing that antioxidants work. And when I first learned about antioxidants, I assumed their mechanism was you block LDL oxidation, you're going to delay the rate at which cholesterol is incorporated into the vascular wall, you're going to prevent the rate of disease progression. But as coronary disease progresses fairly slowly, you really wouldn't expect to see therapeutic benefits for 5 to 10 years, would you? Because it's such a slow process. But in these studies, we saw benefit as early as 6 months. That doesn't make sense. Well, what we didn't understand then, we used to think that it was all about the anatomy, about your percent stenosis. That's all wrong. It's all about your physiology. It's not a narrowed artery that's going to kill you. It's bad physiology. It's endothelial dysfunction, vascular inflammation, reperfusion injury. Here's really where antioxidants help us the most, and this is how they're helping us quickly. So let's discuss this. The endothelium. You were an endothelial cell in our skin. The endothelial cells line our arteries. They're really a large mass of tissue. If we scraped all the endothelial cells off your vessels, we'd have a mass of tissue the size of the liver. It's a chemical factory. The most important chemical it makes is nitric oxide. This vasodilates the blood vessels, resists clotting, and provides the Teflon coating. Everything that causes cardiovascular disease disrupts the endothelium. And the key offenders are oxidized LDL and superoxide. Well, we know that antioxidants block LDL oxidation and neutralize superoxide. So, could antioxidants, by preserving nitric oxide function, produce clinical benefits in coronary syndromes independent of this ability to prevent LDL oxidation and slowly prevent progression of the underlying plaque? Let's examine that. Here we're going to look at a study of antioxidants and endothelial function. The effect of LDL reduction with or without antioxidant protection on coronary endothelial tone. We're going to take 50 patients that required cardiac catheterization for chest pain. They all had hyperlipidemia. 92% had diseased arteries. Only 8% were normal. We're going to measure the response of the artery to the intracoronary installation of acetylcholine. If you're normal, you dilate. If you're abnormal, if your endothelium is abnormal, you're going to constrict. Most of these patients had atherosclerosis. They're going to constrict. So you know that baseline study randomized them to 1 year of different treatment modalities. One group got the American Heart Association Step 1 diet. This is high carbohydrate, margarine with trans fats instead of butter. Nobody should go on a diet like that. The second group got the bad American Heart Association diet and cholesterol reduction with Mevacor and cholestyramine. The third group got the same diet, and they took Mevacor to lower their cholesterol and Probucol. Probucol is a failed drug. It will lower your LDL, but it also will lower your HDL. And 10 years ago, when we became doctors of cholesterol levels as opposed to doctors of patient outcome, we stopped using this drug because the chart looked bad because the HDL was low. It improved outcome dramatically, but we didn't really focus on that. We focused on the HDL, so we stopped using it, so it's no longer on the market. But it does provide antioxidant protection. So this group got cholesterol reduction with antioxidant protection. And then you're going to reevaluate them a year later and look at endothelial function. Now, LDL cholesterol rose on the American Heart Association diet. It fell with both treatment groups. HDL rose a little bit on the American Heart Association diet. With the cholesterol drug scheme, it went up. And with Mevacor and Probucol, it fell. So HDL does fall with Probucol. We know that. That's why people stopped using it. But if we look at endothelial function, does the blood vessel dilate or constrict to acetylcholine? These patients were all abnormal to begin with. They're constricting with acetylcholine. 12 months of the bad diet, they get worse. Coronary disease and endothelial dysfunction tends to progress. Now, with cholesterol reduction, they improve. You lower that LDL, less is going to be oxidized. There's some improvement. But if we lower your cholesterol and give you an antioxidant, you come up to normal. Again, this is integrative cardiology. Lower the cholesterol and provide antioxidant protection, better effect on the endothelium. And the function of your endothelium is the most important predictor of outcome, period. If we can improve the endothelium, you are basically home free. Inflammation. We all know that coronary disease is an itis. It's an inflammatory condition. The best appreciated marker and mediator of inflammation is CRP or C-reactive protein. CRP is a marker and mediator of vascular wall inflammation, reflects the activity of interleukin-6 and other inflammatory chemicals called cytokines. As your CRP rises, your risk continuously rises for new onset cardiovascular disease, the extent and severity of your disease, rapidly progressive coronary disease, heart attack, and death. Unstable coronary disease, unstable angina, heart attack, poor outcome following unstable angina, heart attack, restenosis, heart attack, death following percutaneous intervention, angioplasty and stent, impaired angiogenesis. CRP is a marker of inflammation, oxidative stress, endothelial dysfunction. It is a bad actor. Individuals with active or unstable cardiovascular disease are inflamed. Your circulation's on fire. It's not a focal narrowing in one artery. The whole circulation is red hot. Malondialdehyde is a marker of free radical stress. It means your cell membrane lipids have been oxidized. Here we have healthy people and people with stable angina. You can see their malondialdehyde levels are the same. Here we have unstable angina. The circulation's on fire. They have much more free radical stress. People with heart failure have higher levels of oxidized LDL than normal controls. Active cardiovascular disease is inflammatory. Inflammation, high C-reactive protein. Can we blunt this with antioxidants? Here we're going to look at 110 patients with unstable angina or heart attack, randomize them to E400 or placebo, follow them for 6 months. CRP falls from 17 to 10 in the placebo group because the farther you get away from event, the less inflammation there is, but it fell more in the vitamin E group. Interleukin 6 falls with placebo therapy, it falls more with vitamin E. Antioxidants blunt inflammation. Here we have 70 subjects not on antioxidants, 24 adult onset diabetics without known macrovascular disease, blocked arteries, 24 diabetics with known coronary or carotid or peripheral vascular disease, 23 healthy volunteers, healthy American volunteers. Groups were matched for age, gender, and stature. At baseline, you measure CRP, interleukin 6, treat them with a good dose of vitamin E, 1,200 units a day over 3 months, and then reevaluate. Interleukin 6 is a bad guy. You want a lot of interleukin 6 when you're fighting a pneumonia, otherwise you don't want the stuff. Interleukin 6 levels fell significantly by 50% when the healthy volunteers took vitamin E. Healthy Americans are simply Americans that haven't yet been found to have heart disease or cancer, because that's the way we exit this world. So healthy people just don't have their disease yet, but they're going to get it because they live in the United States, follow the American diet, exposed to the same toxins. So healthy people become a heck of a lot healthier when they take vitamin E. The diabetics had much higher levels of interleukin 6. That made them diabetic, and vitamin E lowered their levels considerably. CRP fell in the normal healthy people, and it was higher and fell a bit more in the non-healthy people. So antioxidants are anti-inflammatory. Let's talk about ischemia reperfusion injury. This is a kind of a difficult concept to discuss. Coronary artery disease is fairly new to Mother Nature. No one had coronary disease 200 years ago. Widespread coronary disease has only been around for about 25 to 30 years, which is a good thing because it allowed me to send all 5 of my kids to college. But Mother Nature doesn't understand this process. Evolution doesn't know how to adapt to coronary disease. Now, let's say you got 3 arteries to your heart, one closes off. All of a sudden, that section of the heart has been shut off its oxygen supply. How's the body supposed to react? Now remember, evolution doesn't understand this process. We've not had a chance to adapt. The body responds as if the heart is being invaded by a bacteria or virus. Because what else would cause heart damage to prehistoric man? No heart, no blocked arteries, so the body responds as if you're being attacked by an invader. And the white cells in that area start to generate free radicals to kill bacteria. And they will deplete all the antioxidants in that section of the heart muscle. And once they've depleted the antioxidants, they're going to destroy the cells via free radical oxidation. But the process goes very slowly. It takes 8 to 12 hours. Why? Because there's no oxygen. You need oxygen to make free radicals. So what we're going to do, you're going to go to the hospital and we're going to open up that artery with a clot-dissolving drug or a balloon angioplasty or stent. So we're going to instantly restore oxygen to this region. Now what's going to happen? The white cells are going to take that oxygen and make a whole bunch of free radicals. There are no antioxidants left in that section of heart muscle, and the cells will rapidly die. So when we suddenly open up your artery, we are going to transiently accelerate the rate at which you digest the heart muscle. This is called reperfusion injury. And it occurs whenever a closed artery is rapidly opened. It will also occur in a vascular surgery when you close an artery and then reopen it. And so we're going to transiently increase the damage. Now, if we don't open up the artery, the heart's going to be lost. We know that, so we won't open up the artery. But in the act of reperfusion, we cause a great deal of free radical stress. And this, if you have a major vascular surgery, say your abdominal aorta is being operated on, you know, when you have an abdominal aortic aneurysm resected, they clamp the aorta, so the lower half of your body is going to be ischemic. It's not going to have any oxygen. So the antioxidant defenses are going to be wiped out. Then the surgeon finishes his surgery, he reestablishes oxygenated blood flow, you get a free radical storm. You don't die after vascular surgery from a surgical mistake. You die from free radical stress, damaging your lungs and your kidney and your liver. Maybe we could do something about that if we gave patients antioxidants along with their surgery when we open up their artery. Here we're going to look at patients undergoing elective abdominal aortic aneurysm resection. Half got put on vitamin E, 600 milligrams a day, 8 days before the surgery, half got placebo. To monitor efficacy, you biopsy the quadricep muscles in the leg at baseline when you're putting them to sleep, at the end of cross-clamping, the ischemic time, and then after you open up the clamp and you reperfuse. So you're actually looking at the cellular structure. So they do the surgery, and we're going to do blood levels of malondialdehyde. That's a marker of free radical stress. In both groups, it rises a little bit during the ischemic phase, but during the reperfusion phase, in the controls, there's a free radical storm, but not in the vitamin E patients. So there's less systemic free radical stress. If we look at the muscle biopsies, there's no damage at control. In the untreated patients, during ischemia, there's more white blood cell infiltration than in the vitamin E patients. And there's during the free radical storm, the white cells are going wild. The mitochondria are being damaged, the cell ultrastructure is being damaged, the cells are dying of the free radical storm following ischemia reperfusion injury, but not in the vitamin E patients. So you would expect that these people would do better. Well, that's kind of an extreme situation, not applicable to everyday life. But what about if you have blood flow problems to your legs, if you have claudication? Let's say you got an 80% narrowing in the iliac artery. Every time you walk, you're going to get angina of your entire leg. And you're going to generate some free radicals. And then when you stop walking, you reperfuse, you're going to get a free radical storm. Is that good or bad? Can we do anything about it? Here we're going to take claudication patients and age-matched controls, put them on the treadmill. And the controls went 200 meters. The vascular patients went as far as they could go. You're going to obtain levels of blood antioxidants and urine microalbumin before exercise and post-exercise. For the claudicators, that would be ischemia reperfusion. So what do you see? In the healthy people, their blood antioxidant defense levels rise. Healthy people with exercise, your antioxidants rise. Not so with the claudicators. Their antioxidant levels fell. Now, the blood's being drawn in the arm. The free radicals are being generated in the legs. But you're generating so much free radical stress, it's spilling into the entire circulation, so your whole body is being exposed to oxidative stress. The leading cause of death in people with lower extremity vascular disease is not gangrene, it's heart attack. Why? Well, I used to think if you got vascular disease here, you're going to have it here. No. Each time you have claudication, you're generating free radicals that are damaging every vascular system in your body. And every time you have angina, you're generating free radicals that are further damaging your situation. If we look at urine albumin, you know, the more protein you spill in your urine, the worse is your outcome in diabetics and everybody, because if you're spilling protein in your urine, that's due to vascular injury of the kidney. Now, the healthy people spilled less protein, the claudicators spilled more because the free radicals were damaging their kidneys. It's damaging the entire body. Now, if you repeated this study, and it's been done, and had them take antioxidants, this wouldn't happen. So you can exercise without fear if you take antioxidants to soak up the free radicals. What about if you have a heart attack? This is the Indian experiment of infarct survival. 125 patients come into the hospital with a heart attack. You're going to randomize them to 4 weeks of treatment with placebo or an antioxidant cocktail. They got 1,000 of C IV for 3 days, then orally, 50,000 units of vitamin A IV for 3 days, then orally, 400 of E, 25 of beta-carotene orally, all of their standard therapies permitted, randomized double-blind study. Let's see what effect a couple dollars a day of antioxidants might have. Vitamin C levels were low in both groups with the heart attack. That generates a lot of free radicals. In the placebo group, you can see over 4 weeks the vitamin C levels rose. They rose much more rapidly in the treated patients. Same thing with vitamin E. Lipid peroxides, a marker of free radical stress, fell a little bit with placebo therapy. They fell a lot more with antioxidants. That makes sense. We give you antioxidants, your levels will go up. You'll squelch the free radicals. There'll be lower levels of lipid peroxides and malondialdehyde, etc. Well, that's interesting biochemistry. CPK is a protein found in the heart muscle, and when the heart cells die, they release the CPK into the blood. The higher your CPK, the larger was your heart attack. More cells died. In the placebo patients, the CPK release was 4,246. It was blunted by a fourth in the antioxidant group. They spilled less CPK. They could do a QRS score of the deviation from normal in your EKG. The placebo patients had higher QRS scores. So it appeared that the antioxidants, those patients had less damage done. They had smaller heart attacks. And if you look at their outcome at 4 weeks, recurrent angina is a bad sign. It means you're at risk for more trouble. 27% with placebo, 16% with antioxidants. Heart failure is blended from 11 to 6%. Low ejection fraction, low pump functions blended from 26 to 16%. They had smaller heart attacks. Complicated arrhythmia, there's less. Non-fatal recurrent heart attack falls from 16 to 11%. Cardiovascular death from 15 to 10%. Total adverse events falls from 31 to 21%. In other words, a couple dollars a day of vitamins spares the lives of 10 out of 100 people who otherwise would have died. That's fantastic benefit. This study was done in India. The study was repeated in Europe, the Warsaw study, 800 acute heart attack patients randomized in the ER to placebo or a cocktail of vitamin C, vitamin E, all other therapies permitted. Total events are blunted again by 10%, from 30 to 21%. Shock, advanced heart failure is also blunted by 50%. All around the world, the heart attacks are the same. Free radical stress, we give you antioxidants, we squelch the free radicals. You won't damage as much of your heart, you're going to have a better outcome. We won't give you antioxidants in the United States because it's politically incorrect. What would the referring doctors think? So we're not going to do that. Also, no one's making any money on antioxidants, so no one's pushing it on physicians. We do make a fair amount of money, though, doing invasive procedures. So if you do have a heart attack, you're going to get an acute intervention, a balloon angioplasty or a stent. And that's okay. I'm happy that we have that capability. So we're going to look at antioxidant status and outcome when you do an acute angioplasty or stent in a patient with a heart attack. 26 patients undergoing urgent intervention for a heart attack. You're going to measure their antioxidant levels before the intervention. You're going to carry it out, and it was technically successful in all 26. However, in 6 of the subjects, while the artery opened and the stent was open, they had what's called the no reflow phenomenon. We dilate the big trunk vessels that are passageways, but the small twig vessels that actually feed the heart constricted. So the artery was open, but there was no blood flow to the heart muscle because the small blood vessels constricted because no nitric oxide free radical stress. So the procedure was a technical success, but the patient got no benefit because of the no reflow. Now, what causes no reflow? Well, here we're going to look at vitamin C levels, vitamin E levels, and levels of glutathione peroxidase in all the subjects. Those who did not reperfuse had lower levels of C, E, and glutathione peroxidase. If you plot blood flow against the vitamin levels, those that had higher levels of antioxidants going in had better blood flow. So the reason in 6 out of the 26 patients the angioplasty worked technically, but it was not beneficial was free radical stress, not enough antioxidants, the patient didn't get a benefit. So in the future, hopefully in the future, we'll give you antioxidants and do the angioplasty or the stent and get a combined benefit. Maybe that's wishful thinking on my part. But if it doesn't work, well, we'll just do another balloon angioplasty, all right? One of the problems with balloon angioplasty, while it's life-saving, is the problem of restenosis, re-narrowing after the balloon angioplasty, so you have to have another one. And what causes restenosis is very, very complicated, but it has to do with scar tissue forming. The smooth muscle cells move into the intima because there's not enough nitric oxide. And one of the reasons there's not enough nitric oxide is not enough antioxidants. So we could hypothesize that antioxidants might prevent restenosis after balloon angioplasty. So there's a study of Probucol. Now remember, Probucol is a great antioxidant, but we stopped using it because it made your HDL fall. But it's a very good antioxidant. Here's a study done with Probucol when it was still available in the American market. We're going to look at 100 patients who are going to get a balloon angioplasty, and they were randomized to placebo or Probucol 1,000 milligrams a day. And the restenosis rate in the placebo patients was 57%, only 23% with Probucol. The need for a repeat intervention was blended from 27% to 15%. Wow, this synthetic antioxidant worked great. Isn't it a shame that we doctors stopped using it because it didn't look good on the chart, even though it had a dramatic benefit? Now, maybe we could bring it back, except it's not going to come back because it's off patent. And there's no money to be made on Probucol, so we'll never see Probucol in the United States, even though it works. However, there's a modified Probucol that the drug companies are working on called AGI 1067, which we're going to see because it's a new molecule, it's patentable. So here's a study of 350 patients getting balloon angioplasty or stent. 2 weeks pre through 4 weeks post, you randomize them to placebo, old-fashioned Probucol, or the new high-tech derivative of Probucol at increasing doses. You carry out the procedure, you reevaluate with IVUS, that's intravascular ultrasound. You can actually measure the plaque area at 6 months. Double-blind protocol. Restenosis with placebo was 38%. With Probucol and its derivatives, it's 26%. The need for repeat revascularization was 18% with placebo. Probucol didn't help, but the new Probucol lookalike did work. And the more you took, the less likely were you to need a repeat intervention. If we look at the volume of the flow area at the lesion site, there's some restenosis in all, but there's less restenosis with the Probucol derivative. And what was really interesting, if you look at lumen volume of another artery that was not stented, with placebo therapy, there's a gradual worsening. The native coronary disease progresses. This was blunted with Probucol and actually reversed with a synthetic antioxidant. So what's exciting to me about this is this synthetic antioxidant regressed anatomic coronary disease in all the arteries, and we're going to see it as a drug. And one of the reasons there's this big movement to ban the sale of antioxidants and close down the health food stores. Why do we want to do that? To get rid of the competition for the drug companies to come out with high-priced synthetic antioxidants. Although Mother Nature, I think, does a better job. Now, let's say you have the heart attack and we don't give you antioxidants, and you get a stent, you get a balloon angioplasty, we don't give you antioxidants, you plug them again, we're going to do open heart surgery. Why not? Let's put in bypass grafts. Now, one of the problems with open heart surgery is during the procedure, the heart, when you have on-pump open heart surgery, the heart is going to be starved of oxygen for a period of time, and then you're going to start the heart and reperfuse it, you're going to get a free radical storm. So open heart surgery on pump causes ischemia, reperfusion injury, free radical storm. And that's going to compromise the heart and every organ in the body. So let's say, why don't we give you antioxidants going into the open heart? Will that improve your outcome? Because antioxidant defenses fall, free radical activity soars during coronary artery bypass surgery, compromising all aspects of cardiovascular function. So here we got a study, 81 patients, 45 were stable, 36 were unstable. The stable patients were randomized to a 4-week program of antioxidants, 600 of E for 4 weeks, allopurinol, that's a gout medicine, but it's a great antioxidant, and vitamin C 2 days pre versus 1 day post. Group 2, they were stable, they didn't get any antioxidants. Groups 3 and 4, they were unstable, they were hot, they needed surgery within 3 days, so they got either 3 days of antioxidants or no antioxidants. Then they undergo surgery, and as you would expect, vitamin E and vitamin C levels fell with the stress of surgery, but in the group that was supplemented for a month or 3 days, the levels do not fall as much as the unsupplemented ones. Vitamin C levels fell, but they actually rose in the group that took it for a month. They were maintained in the group that took vitamin C for 3 days. So if you take the antioxidants, your levels stay higher. What effect on outcome? In the stable patients that took antioxidants, 25% had an arrhythmia, 24% of those that didn't take an antioxidant, that's no difference. Ischemia on the EKG showing that the heart muscle is not getting enough blood and oxygen occurred in 52% of those that did not take antioxidants, 20% of those on antioxidants. That's a benefit. Heart attack, we hate it when we send you for open heart to prevent a heart attack. We don't like it when you have a heart attack. That occurred in 8% of those in the placebo group, 5% of those on antioxidants. That was not a statistically significant difference. Now let's look at the sicker patients, those that were hot, that needed surgery within 3 days. We would expect that they would have a higher operative event rate, and indeed they did. Those that needed urgent surgery that did not take antioxidants, 42% had an arrhythmia, only 12% of those that took antioxidants for 3 days. Ischemia on the EKGs blended from 58% to 18%. Perioperative heart attack is blended from 32% to 6%. Which group would you want to be in? You need an open heart, we can give you antioxidants or not and decrease your perioperative infarction rate from 32% to 6%. Wow, this study's been repeated, same result. But we're not going to do that here in the United States. No, we're not going to do that. So if it doesn't work, we can do a heart transplant because Medicare pays for it. Now, one of the problems with a heart transplant is you have intense free radical stress because your immune system is trying to reject the heart and the drugs that you have to take cause free radical stress. And the problem with your transplanted heart is rapidly progressive coronary disease due to free radical stress. So the transplanted heart plugs up its arteries quite rapidly due to free radical stress. Well, let's give you antioxidants. Here we're going to take 56 patients to get a heart transplant. You do a heart cath right after the transplant, show the arteries look good, and you randomize them to a cocktail of E, C, and beta carotene or placebo. You repeat their heart cath at 1 and 2 years. In the placebo patients, the arteries progressed by 6.3% the first year, 9% the second year. Those that took vitamins, it was 2.8 and 3.3%. Those that were actually compliant with their vitamins and actually took them, I don't know why you'd undergo open heart surgery and then not do what the doctors say, but some didn't. Those that actually took them, you can see they had much less disease progression. Coronary disease following a transplant due to free radical stress, we give you antioxidants, you don't get as much coronary disease. Antioxidants in critically ill surgical patients. Many surgical patients, trauma patients, survive the insult only to die later of hospital-acquired infection, adult respiratory distress syndrome, multi-organ system failure. Oxidative stress contributes to the respiratory disease and the kidney failure in the critically ill. Antioxidant deficiency compromises the immune defense against serious infection. Could antioxidant supplementation improve outcome in surgical patients? Here we're going to look at just under 600 surgical ICU patients. Most of them were trauma victims. At the time of the admission to the ICU, you randomize them to standard care or standard care plus vitamin E, 1,000 units a day, vitamin C, 1,000 milligrams IV every 8 hours. And then you follow them over a month. Same nurses, same doctors. Those that took antioxidants were 21% less likely to develop pneumonia. The pneumonia rate falls from 15 to 12%. Adult respiratory distress syndrome, 14% risk reduction. Multi-organ system failure, 57% risk reduction. Those on antioxidants got off the ventilator 1 day earlier. They got out of the ICU 1.2 days earlier. They got out of the hospital a half a day earlier. 28-day mortality was reduced by 57% with antioxidants. Mortality in the ICU fell by 68%, from 3 to 1%. Hospital mortality falls from 46%. A couple dollars a day for basic antioxidant vitamins really improved their outcome. Sadly, in American hospitals, you will not be treated with antioxidants because we doctors don't believe in nutritional medicine. I guess we don't read the journals, or we don't think anymore, or maybe we don't care anymore, or we're so worried about what the other doctors think we don't have the strength to do the right thing. But if we did, our patients would do so much better. EECP, which we'll talk about in a few weeks, enhanced external counterpulsation, is my treatment for inoperable or recurrent cardiovascular disease, does have an antioxidant effect. We're going to look at malondialdehyde levels, markers of free radical stress. In healthy people, it's 3.8. In patients with coronary disease that take drug therapy, nothing happens. In patients with coronary disease that are treated with external counterpulsation, malondialdehyde levels fall. External counterpulsation improves endothelial function, blocks oxidative stress. Chelation therapy, which we're going to talk about in a few weeks, heavy metals, lead, cadmium, and mercury, cause free radical stress. They catalyze the conversion of superoxide and peroxide into hydroxyl lye. Chelation therapy simply removes these toxic metals from your body. We would expect that chelation would thus improve your antioxidant defense system and get rid of some of the causes of free radical stress. Here we have 16 patients with various medical conditions, some healthy, some sick. Measure the baseline malondialdehyde level. Following 16 IV chelations over 5 weeks, it falls. You get rid of the cause of the free radical stress. Lo and behold, the free radical stress is attenuated. Far infrared sauna sweats out toxins and is of great value in patients with cardiovascular disease and heart failure, well documented in studies done at the Mayo Clinic and in Japan, where it's a fairly standard therapy. 28 subjects with at least one risk factor, randomized them to 2 weeks of daily far infrared sauna or no sauna. Systolic blood pressure falls. 8-epi-PGF is a free radical that damages the nucleus, plays a role in cancer. It was blunted by detoxification with far infrared sauna. We've been talking about antioxidants protecting the heart. Are there going to be side effects? You know, the drugs that we use to treat your heart tend to compromise other organ systems. The beautiful thing about integrative cardiology is the nutritional supplements that improve the function of your heart can only improve the function of every cell and organ in your body. So let's talk a little bit about antioxidants and the kidney. Contrast nephropathy is the term for when I give you too much X-ray dye and it sludges up in your kidney and damages the kidney. It's favored by pre-existing kidney disease, diabetes, being dehydrated, or being on other drugs that damage the kidneys. Free radical stress plays a role. In animal models of contrast nephropathy, antioxidants are protective. Here we're going to take 83 patients with chronic kidney disease give them the same dose of X-ray dye, give them IV fluids before and after as we would do in the hospital setting, randomize them to N-acetylcysteine, 600 milligrams twice a day, the day before and the day of the procedure, or placebo. And you're going to follow them for 2 days. In the placebo patients, the creatinine rose from 2.4 to 2.6. A normal creatinine is about 1.2. So these people had kidney disease. The X-ray dye compromised their kidneys. Those with kidney disease that had the heart caths and had the antioxidant, their creatinines fell. A 0.5 milligram per deciliter rise or fall in creatinine is significant. That occurred in 21% on placebo, 2% on N-acetylcysteine. If your baseline creatinine is higher, above 2.5, your risk is greater. Of those patients on placebo, 42% got into trouble, none on N-acetylcysteine. And even all cardiologists in the United States, if you're going to have a heart cath and there's a problem with your kidney, they're going to give you N-acetylcysteine. Now, they're not going to give you a low-cost N-acetylcysteine capsule, but it exists in a drug form called Mucomist that tastes like skunk water. It really makes you gag, but they're going to give you that. My patients will take a capsule of N-acetylcysteine that doesn't taste bad, but it's an antioxidant that protects the kidneys. As a matter of fact, if I put people with kidney disease on N-acetylcysteine, even if they're not having a heart cath, I'm seeing their kidney function improve, which is kind of neat. How about if we just treat our kidney patients with N-acetylcysteine? Would it be helpful? 134 dialysis patients with end-stage renal disease, 12 had a prior angioplasty, 18 with a prior bypass, none on antioxidants. This is a high-risk group. People with kidney disease are at great risk for cardiovascular events. We're going to randomize them to receive N-acetylcysteine 600 milligrams twice a day, or this is what a bottle looks like. It's very inexpensive, maybe 20 bucks for a month's supply, or placebo. And you're going to follow them for about 15 months and look at cardiac events. And first, let's look at their oxidized LDL levels. Remember, oxidized LDL is the bad actor. It's 5.5 with placebo, 1.3 with N-acetylcysteine. That's pretty good. What effect on outcome? The risk for a stroke falls by 69%, from 10 to 3%. So 7 out of 100 people who were going to have a stroke didn't because they took N-acetylcysteine. The risk for new onset peripheral vascular disease falls from 17% to 11%. Cardiac event, 30% risk reduction from 20 to 14%. Wow, that's pretty good. The primary endpoint, a composite of all these adverse cardiovascular events, falls from 47% to 28%. Wow, 20 out of 100 people that were going to have an event didn't have it because they took N-acetylcysteine for 30 cents a day. Wow. Antioxidants can protect the heart and the kidney and the lung, and why not? Why are we even surprised? Chronic obstructive pulmonary disease from smoking involves free radical damage to the lungs and cadmium. The tobacco plant concentrates cadmium. When we smoke, we get cadmium in the lung and it never leaves. We stop smoking, our lungs continue to deteriorate because the cadmium is still there, causing free radical stress. And inflammation. We've got 169 patients symptomatic COPD, 84 get standard therapy, 85 get standard therapy and N-acetylcysteine 600 milligrams a day. Over the 2-year follow-up period, 75% on standard therapy had an exacerbation, only 54% on antioxidant therapy. 2 or more exacerbations, 49% standard therapy, 26% N-acetylcysteine. Sick days, missing work, 155 with standard therapy, 82 with N-acetylcysteine. How's that to improve your economy? If your workers can go to work because they're not sick, that would seem to be a good idea. N-acetylcysteine and nitrate tolerance. When you take a nitroglycerin, every molecule of nitroglycerin is converted to nitric oxide in a chemical reaction that uses up glutathione. And that's okay if you're just popping a nitro every now and then. But if I put you on continuous nitrate therapy, the long-acting pills or the patch, I'm constantly soaking your circulation with exogenous nitric oxide. And in this process, I'm wasting glutathione. Your body can sense the high level of nitric oxide. Your endothelial cells stop making it. Instead, they make Superoxide. The superoxide degrades the nitric oxide I'm giving you and what you're still making, and all of a sudden the nitroglycerin patch doesn't work anymore because we've caused free radical stress and inflammation. So we say you have nitrate tolerance, we give you a higher dose. That works for a while, and then you develop tolerance. People who take long-acting nitrates are more likely to die and have an event than people who don't. They improve your symptoms, but they compromise your long-term outcome. They're not a really good therapy. And it's due to oxidative stress and wasting glutathione. Well, N-acetylcysteine is an antioxidant, and we convert it into glutathione. So logically, maybe if you're going to be on a long-acting nitrate, we ought to give you N-acetylcysteine with that help. Here we're going to take 200 patients with unstable angina. They all quieted down with medical therapy. They're all on the same drugs. You randomize them to receive a 10 milligram nitro patch and a placebo pill, a placebo patch and N-acetylcysteine. One group gets the nitro patch and the N-acetylcysteine. Another group gets double placebo. You're going to follow them for 4 months, randomized double-blind format. If we look at ischemic ST depression on a 24-hour EKG, that's a sign of ongoing ischemia, supply-demand mismatch. With placebo therapy, as you get away from the event, it falls from 24 to 15%. The group on N-acetylcysteine did better, falling from 37 to 16%. They did better. N-acetylcysteine had a greater anti-ischemic effect than did nitroglycerin. But if you combine nitroglycerin and N-acetylcysteine, you get the benefits of the nitro without the tolerance. They had the best result, falling from 25 to 4%. If we look at outcome, which is really what we're concerned about, N-acetylcysteine didn't blunt the need for revascularization. The nitro patch did. The nitro patch and N-acetylcysteine, that group did best. They had fewer heart attacks, fewer total events. The nitro makes you feel better, it vasodilates you, but you get the tolerance, which we can blunt with N-acetylcysteine and give you antioxidant protection. You get the best drug effect, you get the best antioxidant effect, you have an integrative effect, you have the best outcome. Vitamin C has been shown to do this as well. Pomegranate juice. Everyone's heard about pomegranate juice, rich in antioxidants. We're going to help the endothelial cells make nitric oxide. Here we got 45 patients, stable coronary disease, abnormal stress perfusion studies. You do a baseline stress perfusion study, randomize them to pomegranate juice, 240 cc's a day, or a placebo juice. You repeat their stress perfusion study at 3 months. Angina frequency worsened, number of angina episodes per day worsened with placebo therapy. It decreased with pomegranate juice. The stress test findings worsened with placebo therapy. They improved with pomegranate juice. They walked farther and their nuclear scans looked better simply by drinking an antioxidant juice. That's pretty neat. But all this exercise, it makes me tired. Giving a talk like this is fatiguing, and it exposes me to free radical stress. I ran 18 miles today. That exposes me to free radical stress. So I think I need to be energized a little bit. So what I'm going to do, I'm going to sneak over here and turn on my Active-Air machine. The Active-Air machine was invented in Europe, and it's been used in Europe for about 5 years. It's now coming to the United States. And I'm going to explain how this works. What we're doing with Active-Air, we are exposing air to light of a specific frequency in the presence of a catalyst. And what that is going to do is convert oxygen to singlet oxygen. It's bumping the electrons into different orbitals. It's reversing the spin of the electron. Technically, it's a free radical. It will last 2 millionths of a second. So it instantaneously reverts back to oxygen. The light energy that we put in must come out. The law of conservation of mass and energy, right? And the energy that is released when the singlet oxygen reverts to oxygen is stored in the water molecules of this humidified air. Technically, it's stored by altering the angle between the oxygen and the hydrogen atoms in the water molecule. So I'm breathing room air that contains water molecules that contain biological energy. The air, the energized air is absorbed across my lungs, it enters my blood, it's picked up by every cell in my body and will be converted to biochemical energy. I will make more ATP. And I don't quite understand how it works, but it does have an antioxidant effect. If we look at our total antioxidant status by the Randox methodology, it increases by 20%. If we look at white blood cells in tissue culture, with or without active air, those receiving the active air make fewer free radicals. So it has an antioxidant effect simply by breathing this energized air. What's really cool about this is it's not giving me oxygen, but I'm going to take up 7% more oxygen from the air I breathe. If you measure the oxygen concentration of the air I exhale, it's going to be lower because my cells are taking it up. If you measure the oxygen concentration in the venous blood that leaves my cells that's going back to the heart, it's lower because my cells are taking up more oxygen. They're more efficient. They're going to make more energy. Autonomic function improves. Heart rate variability falls. Athletes do better. My patients with coronary disease, they're having chest pain. We have them do this and their chest pain gets better. My running is much better. I'm going to run a marathon in about a month. I'm going to use my active air, and hopefully I won't fall apart at the finish line like I normally do. So this is providing me antioxidant protection, and I think that's kind of neat. Selenium in prostate cancer risk. You know, free radicals cause cardiovascular disease, they cause cancer. Let's look at that. We've shown that if your selenium levels are low, you're more likely to have arterial disease. Let's look at cancer risk. 974 men with at least 2 episodes of non-melanoma skin cancer obtained baseline selenium and PSA levels. Randomized them to receive selenium 200 micrograms a day, which is in a multivitamin, or placebo. Repeat the selenium blood level at 1 year. Monitor for recurrent skin cancer or any new cancer over a 5-year follow-up period. Randomized double-blind protocol carried out in the eastern U.S. where the typical dietary selenium intake is 70 micrograms. So you're giving a lot more than the average American takes in. Selenium levels were 115 at baseline. They didn't change with placebo therapy. They rose significantly to 190 with the supplement. Well, that makes sense. We give you selenium, your levels are going to go up. Now, there was no effect on skin cancer. No effect at all. But of these patients, 48 developed prostate cancer, 35 in the placebo group, 13 in the selenium group. So by taking selenium 200 micrograms a day, your risk of developing prostate cancer was only 37% of those on the control group. Put in other words, your risk of developing prostate cancer fell by 2/3. Your risk of developing prostate cancer fell by 2/3 simply by taking selenium. Now, if we look at men that had higher levels of selenium, going into the study, there was no protection. The lower was your baseline selenium level, the greater was your protection. The men that had selenium levels that were really low, below 106, those that were treated with selenium, only 1 got cancer. Those on placebo, 13 did. The risk reduction was 92%. It didn't matter the time course or what your PSA level was. Selenium provided phenomenal protection. 63% reduction in prostate cancer risk. No reduction in skin cancer risk. 37% decrease in total cancer risk. 50% decrease in cancer death risk. Decrease in combined prostate, lung, and colon cancer incidence. 17% reduction in all-cause mortality. For heaven's sake, why aren't American physicians telling American men to take selenium? Because we're worried about what our peers will think of us. We're not worried about your outcome. If you did this with breast cancer, you'd see basically the same thing. It's a very similar physiology. We are all vitamin and mineral deficient. It's giving us heart disease and cancer. It seems to me, maybe I should give you antioxidants and you won't have as much heart disease and cancer. But this is considered alternative medicine. Well, it's alternative then to bad medicine, which is drugs and surgery for all. Now you're going to be taking all these vitamins and you need to drink something to wash them down. I'm going to suggest tomato juice. Adult subjects with well-controlled diabetes, we're going to measure lag time to LDL oxidation, CRP levels. We'll randomize them to vitamin E, 800 units a day, or tomato juice, which gives you 300 C, and lycopene. Lycopene's a very interesting antioxidant. Or placebo, you repeat the measurement at 4 weeks. CRP levels don't change with placebo. They fall with vitamin E. Tomato juice doesn't do a whole lot for CRP. Lag time to LDL oxidation, vitamin E helped, as did tomato juice. So tomato juice will block LDL oxidation. So wash your vitamins down with tomato juice. Lycopene, we get this from cooked or stewed tomato products. Let's look at lycopene in patients with localized prostate cancer. 26 men with newly diagnosed, still felt to be localized prostate cancer, and they're going to undergo prostatectomy, hopefully for cure. Now, you're going to record their baseline PSA and lycopene levels, all get the standard National Cancer Institute recommendation, 5 servings of fruits and vegetables each day, randomize them to placebo or lycopene, 15 milligrams a day. The product was Liomato. At 3 weeks, you repeat the PSA and lycopene levels, you carry out a radical prostatectomy, look at the content of lycopene in the prostate, the size of the tumor, and was the tumor confined to the surgical field or had it extended. That means that it was no longer local and they had not been cured. Double-blind protocol. Plasma lycopene levels rise with supplementation. That makes sense, and it gets into the prostate. You take it orally, it goes into the blood, it makes it into the prostate. Tumor volume. You'd like to see the tumor smaller than 4 centimeters squared. Above 4 centimeters squared, that's a bad sign. And the controls, basically half had, 45% had below 4.4 centimeters squared, 55% had above. In the lycopene group, they had smaller tumors. Their cancers had shrunk. Only 20% had tumors greater than 4 centimeters squared. Tumor confined to the prostate, in other words, you got it all, the patient's cured. 27% of the controls, 73% of those on lycopene. The lycopene killed the cancer cells. I wonder what would have happened if they took more lycopene over a longer period of time. Maybe the cancer would have vanished. We don't know, but this seemed like a pretty good integrative medicine approach. Lycopene for 3 weeks, then surgery with a greater cure rate. The major points of my discussion is that undefended free radical attack leads to LDL oxidation, vascular inflammation, and endothelial dysfunction. LDL oxidation must occur before coronary disease can develop. Antioxidant vitamin deficiency is associated with an increased coronary risk between and within societies. That's the European cross-cultural study. Antioxidant supplementation inhibits test tube LDL oxidation, controls atherosclerosis in animals. In humans, supplementation is associated with a 30 to 50% decrease in the risk of developing coronary disease over 4 to 10 years. That's the Nurses' Health Study. In patients with known coronary disease, supplementation helps stabilize the narrowings, and with LDL reduction can actually open up the arteries. Acute vascular syndromes, unstable angina, heart failure, heart attack, are characterized by oxidative stress, vascular inflammation, and endothelial dysfunction. Oxygen-derived free radicals mediate reperfusion injury, compromising your outcome from surgery or clot-busting therapy. Antioxidants restore endothelial function, attenuate reperfusion injury, have an anti-inflammatory effect, producing clinical benefits above and beyond that related to their basic anti-atherosclerotic, anti-LDL oxidation effect. Vitamin E has been shown to decrease 2-year event rate in patients with established coronary disease by 50-70%. That's the CHAOS study. Vitamin C, which we'll talk about in a few weeks, decreases disease progression over 10 years by 2/3 and event rate by above 50%, regardless of the baseline degree of atherosclerotic narrowing you may have. Antioxidants improve outcome following bypass surgery, angioplasty, heart attack, TIA, even cardiac transplantation. Antioxidants protect the kidneys, lung, brain, prostate, other internal organs. Antioxidants are protective against certain malignancies. Environmental and dietary toxins are depleting our antioxidant defenses. Dietary vitamin sources are lacking, not utilized in our society. Otherwise, vitamins wouldn't help us. We're all deficient. We need to be supplemented. Therefore, supplementation in a dose individualized to one's health status is recommended for all of our patients. Great benefits are in store for our patients and for society in general as we learn more about nutritional medicine, gain access to second generation or comprehensive nutritionals. And I don't want you to go out and take vitamin E or selenium or vitamin C. I want you to go out and take a broad spectrum vitamin and mineral supplement. And by this I mean a 6-a-day vitamin and mineral. All the health food stores have them. My patients often take Basic Preventative 5, which is iron-free, 2 in the morning, 2 at lunch, 2 at dinner, and my patients do so much better now. When I was 35, I was tied with 2 older guys as the leading admitter of cardiology patients to my hospital. Now I hardly admit anybody. The big difference was the vitamins, the minerals, the essential fatty acids. Now, most of the studies of vitamins have used 1 or 2 or 3 vitamins. Those aren't really good studies. There has never been a study of a broad spectrum 6-a-day vitamin until now. And we are participating in the TAC study, Trial to Assess Chelation Therapy. We're going to recruit just under 2,400 subjects. To be involved in TAC, you must have had a heart attack at some point, be 50 years of age, and be stable. All TAC patients will receive standard post-heart attack medical therapy, and then you're going to get 30 IV treatments over 30 weeks, then once a month for 10 months, and a nutritional supplement. You'll be randomized to IV chelation therapy, which removes lead, cadmium, and aluminum. We'll talk about chelation therapy in a few weeks, or a placebo. There'll be secondary randomization to a 1-a-day multi, which is not that effective, or a 6-a-day multi. So half of the subjects are not going to get chelation therapy. And of those patients, we'll be able to compare a 1-a-day versus a 6-a-day multi in how you do following a heart attack. And we're going to see that the 6-a-day multi group has a tremendous benefit and outcome. Because I've seen that in my own patients. You could say that my practice has been the model of the TAC study. My patients, I used to not put you on vitamins. I started putting you on a comprehensive program, and you've done very well. If any of you would like to participate in this study, we would love to have you in the study. We need volunteers, and we need to recruit more patients. We want this to be a successful study, because if we can enroll enough patients and show that vitamins work and chelation works in people with a prior heart attack, then the NIH will give us money to study vitamins and chelation and detox in people that have not yet had a heart attack, which is what we want. So to be intact, you must be 50 years of age, you must have had a heart attack at some point, and you need to be 6 months out from bypass surgery or balloon angioplasty. And that's all I have to say. Thank you very much for your attention.